Good afternoon to our esteemed guest of honor, Dr. Nur Saliha binti Ibrahim Tamin, Senior Principal Assistant Director, Head of Cancer Prevention and Control Unit, Ministry of Health, Prof. Brandes Popema, the President of Sunway University, Dr. Xiao V. Ken, CEO of Sunway Medical Center, Mr. Pang Siming, Founder, Group Managing Director, AP Plus Group, distinguished panelists, ladies and gentlemen, thank you for joining us today. My name is Zaim from Sunway University, and I'm pleased to welcome all of you today. Today's event is put together by the School of Medical and Life Sciences, Sunway University, and EP Plus Group, Sdn Bhd. As you can see from the event title, Behind the Scene, Shedding Light on Colorectal Health, we are excited to have a rapid firing Q&A session with the expert to find out more about colorectal health. Even better, audience today can get their question answered live by the professional. We are honored to have 6 distinguished experts from different specialists, such as gastroenterologists, colorectal surgeon, oncologist, cancer biologist, and public health expert, to have a dialogue on colorectal cancer health topics. So without further ado, let's welcome Mr. Pang Siming, Founder, Group Managing Director of EP Plus Group, to deliver the opening speech.
Thank you, Mr. Chairperson. Thank you. Dr. Nur Saliha binti Ibrahim Tamin, Senior Principal Assistant Director, Head of Cancer Prevention and Control Unit, Ministry of Health, Malaysia. Professor Brandes Popena, President of Sunway University. Sorry if I pronounce it wrongly. Professor Mahindiran Sangguran Nai, Vice Chancellor, Sunway University. Dr. Xiao Wei Ken, CEO of Sunway Medical Center. Professor Dr. Raja Ali, Dean of School of Medical and Life Sciences, Sunway University. Distinguished speakers and guests, ladies and gentlemen, good afternoon and a warm greeting to all. To begin with, I would like to record my earnest appreciation to the organizer of this event, the School of Medical and Life Sciences of Sunway University, for the partnership extended in raising the awareness of colorectal cancer in Malaysia. At EP Plus Group, we subscribe to innovation for better lives for patients, healthcare professionals, EP Plus Group staff, which we fondly call them EPians, and the community around us. We innovate by providing a range of European pharmaceuticals and medical products to enhance patients' health in targeted therapeutic areas. It includes a unique medicines ranges from common gastrointestinal tract disorders such as constipation, acute diarrhea, irritable bowel syndrome, to more severe disease such as colonic polyps, stomach and colon cancer that would require regular screening since year 1997. Ladies and gentlemen, fast forward into 2023, colorectal cancer, the second most common cancer in Malaysia, is also the third leading cause of cancer-related deaths in our country, is fast becoming a growing medical healthcare burden. As the prevention is better than cure, prevention is the panacea. Naturally, it is a great honor for EP Plus, both corporately and on a personal level, to support the immense responsibility to forge a common purpose. We stand united with every stakeholders in the country to shed light on the topic which afflict significant numbers of Malaysians. Ultimately, it is to encourage every Malaysian above the age of 50 in our countries to call to action. Without much ado, once again, I would like to thank and congratulate Professor Afandi, the Dean, School of Medicine and Life Sciences, Sunway University, for putting this imperative on the Malaysian radar. Thank you.
Thank you very much, Mr. Pang Siming, for the wonderful welcoming speech. Now it's my pleasure to invite our next esteemed guest of honor, Prof. Brandes Sopema, the President of Sunway University, to say a few words.
Ladies and gentlemen, I am not going to attempt to pronounce the names of all of the guests because fortunately that's been done 2 times now. So not necessary. I welcome all of you to Sunway University. Second, I could have been talking about colon cancer because some of you may know that my original profession is a pathologist. So that's what I used to do, teach about cancer, but not today. Today, I will tell you a little bit about Sunway University and why we also consider things like this very important. So Sunway University, private, not-for-profit university, 12 years old, takes pride in a couple of things. First of all, in our holistic education. So to us, university training is not just about the knowledge and not even just about the skills. And when we talk about skills nowadays, it's about communication skills, it's about digital skills, it's about English language skills, all very important in the workplace. But to us, equally important are the values and the mindset of our students. Values are the Sunway values, Sunway company. And those values are number 1, integrity. Number 2, humility. And I always explain to the students, I'll do it again today, humility does not mean that you cannot be proud of your achievements. Humility means that you know that you are not better than anybody else because of those achievements. The value of each individual is the same. So that is what humility means. There's no contradiction with being proud of your achievements. Number 3, the mindset. What we want to achieve is that all of our students, when they graduate from Sunway University, they know about sustainable development, they know about planetary health. So the goal is when they look at their first job, that they think, is this a company that is going to make this a better world, or is it going to make the world worse? So that's what we want to achieve there. And then the other one is entrepreneurship. That does not mean, and literally all of our students will be getting courses in, literally all courses in sustainable development, in planetary health, and in entrepreneurship. And entrepreneurship, again, does not mean that all of them will be establishing their own company. What it means being entrepreneurial. When you see opportunities, you take those opportunities. So those are important things. That should be the DNA of a Sunway graduate. You should recognize them by that. And actually, the thing is that employability, which is the other thing that's extremely important, that's why people send their children to the university to get a good job. That's why they pay money. Our employability is the best in the country. Our employability preparation programs are the best in the world, actually, because when you look at the International Student Barometer, Sunway University is number 1 in the world in career preparation. Not Malaysia, not Asia, in the world. Actually, in the International Student Barometer, we have the highest satisfaction of our students in Asia. We don't know where we stand in the world because they don't give those data, but we know we are number 1 with more than 94% satisfaction of our students, number 1 in all of Asia. So those are really important things to us. And things like knowing about sustainable development and being entrepreneurial actually makes people more employable. You know, it's the good thing to do, but it's also something that helps the student being more employable. All companies need to have people that know about environment, social, and governance. And they don't have those people, so we are training them. Second thing, of course, is research. If it comes to research, we also try to have as much as possible of our research to focus again on sustainable development and on planetary health. Now, you might think that's not a very fruitful way of doing it, but in actual fact, our number of publications has been going up very rapidly. This year, in fact, it will grow by 40%. So this year, I'm expecting something like 1,400 publications of Sunway University. Now, if you compare that to the public universities, much bigger, but we are now coming close to between 30 and 40% of the number of publications of the large Malaysian research universities. And in the next year, we will be catching up further. Other thing, that type of research is being cited very well. So our citations per paper over all areas, from business to the School of Medical and Life Sciences, engineering, and anything in between, our citations per paper are better than any university in Malaysia. In fact, than the big majority of universities in the world. They are better. No, they are not as good as MIT. They're not as good as KAUST, King Abdullah University of Science and Technology, and not as good as Imperial College. But they are better than Harvard, Oxford, Cambridge, etc. NUS, NTU in the past 2 years. So 2022 and 2023, actually right now, if you would look now at the publications of 2023 citations per paper, we would be #1 in the world. So the quality of the publications is very high. Now, third thing that a university should do is community outreach, sharing the knowledge, and that's what today is about. And we have Prof. Raja. Actually, we also have Prof. Abi, the former dean of the School of Medical and Life Sciences, Prof. Raja now. And the School of Medical and Life Sciences is a growing school. We will be starting postgraduate training, so specialist training. We will also be starting an undergrad medical school at Sunway University. So this part, the outreach when it comes to medical, will become more and more important in combination also with SunMed. You know, you should go and have a look at the new facilities at SunMed. You know, they're really fantastic. Towers D and E are open now, Prof. Sao, right? And Tower F will be coming. So there's going to be a big boost of research. There's going to be a big boost also of outreach into the community to give more information about different diseases. Because in the end, there's just two things. One is prevention. The other one is early detection. And the rest is damage control. Thank you.
Thank you very much, Prof. Gibran, for the insightful opening remarks. Now, I would like to invite Dr. Nur Salihah binti Ibrahim Tamin, Senior Principal Assistant Director and Head of Cancer Prevention and Control Unit, who is here today on behalf of Datuk Dr. Razi, Director General of Ministry of Health Malaysia, to officiate this public forum.
Thank you, Mr. Chairperson. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Salam sejahtera. Salam Shimadani. Well, thank you for inviting Minister of Health to be part of this event today. You know, I feel grateful. And I'm conveying Datuk Dr. Razi's apology for unable to be here today for other pressing matters that he has to attend. And I'm here to convey his speech. Well, distinguished officials, I will pronounce them because I do not know how to pronounce, but I'll ask later how the spelling is like. I'll try to pronounce. And of course, Yang Mulia Dr. Raja Afandi Raja Ali, whom I know since before, Dean of School of Medical Life Science now of Sun University, distinguished speakers, yes, ladies and gentlemen. First and foremost, I would like to express my sincere gratitude to organizers of this event, the School of Medical and Life Science of Sunway University, supported by EP Group, EP Plus Group. It's because of their efforts that we are here today for a uniform purpose, common purpose, to shed light on a topic that is most significant, which is called the health. It is a passionate, especially if I advocate for public health. I'm truly honored to be part of this discussion, which is close to my heart. Ladies and gentlemen, colorectal cancer, which is the second most common cancer in Malaysia, or the first common cancer among males and second among females, is actually also the third leading cause of death in Malaysia. And majority of the cases actually diagnosed late at 70%, where of course significant impact on mortality is there, which of course we have to do something about it. And you know, this means that a staggering number of people receive the at late stages, where the treatment ability or treatment chance is less, you know, and they are faced with vulnerable future and difficult battle of the treatment. The disease knows no boundaries when it comes to age. It affects individuals from all walks of life, while colorectal cancer primarily affects individuals of age of 50 and above. And now we are seeing a significant number of young age group being affected by colorectal cancer. This is worrisome because something that we have to do something about. It might affect the whole nation if we don't do something about it. Several factors that contribute to these concerning effects, concerning trend of colorectal cancer. The lifestyles, you know, as we know, the unhealthy diet that we live to eat, the inactivity, the sedentary life, you know, the obesity, which Malaysia is, well, the most obese nation, as we know. And of course, the metabolic disease that we have to see in Malaysia. Prevention, of course, is important. It's very important, as mentioned by the President just now. Prevention is important, but of course, screening is important because to tackle this, we need to prevent and we need to screen. We need downstage the disease at early stage now. So there's more that we have to do together to tackle the issue in Malaysia. Colorectal cancer screening is currently provided by the MOH at health clinics since 2014. Operation screening targeting 50 to 75 years old. However, the uptake is still suboptimal. The National Health Mobility Survey in 2019 revealed that it's still low, and we hope the new survey that we're conducting now will see a better coverage for Malaysia. For screening, I mean. It is impressive for healthcare professionals, public and private, to take the initiative and activity to reach the asymptomatic individuals, because asymptomatic is where you should tackle. Those with symptoms, of course, we need to tackle as well, but to prevent is those asymptomatic individuals. We should encourage them to come forward for screening. We should do actively, should encouraging them to come forward, not just rely solely on their voluntary action to the screening. We have to really ask them to come forward for screening and do more promotion on that. Another crucial aspect is that detection of potential cancer at earlier stage is something that we have to look upon. You know, when stage of cancer detected at later stage at 3 and 4, we must do something downstage to stage 1 and 2, where the treatment is much better compared to later stage. And the prognosis of better to the patient. Healthcare professionals should actively advocate screening at earlier stage, you know, at early age, at 50 or perhaps early age if you have risk factor, higher family members 10 years younger. But of course, you have to advocate them, encourage them, tell them the importance of screening. Of course, the president as well is very important. Ladies and gentlemen, the key to success lies in raising awareness among the individuals, among the community. We must garner support from all stakeholders, the government sectors, the private hospitals, the GPs, the NGOs, the policymaker like us, to work together to reach the community and to get our target achieved. To achieve our goals, we would also need the active participation from community. Everyone has a role in promoting health. including colorectal cancer. Whenever possible, they should advocate on screening, initiate, telling the family members, the friends on the importance of screening. And of course, they themselves should come forward for screening, not just telling others. Ministry of Health has already incorporated in the module of COSPEN. You guys have heard about COSPEN. It's Community Health Perkasa Negara, where we have volunteers in community. We included our modules on the importance of colorectal cancer, the importance of screening, and the effects on colorectal cancer, for them to be empowered to tell the community on the importance of colorectal cancer health. So we hope with that effort, we will see more patients, we will see more population come forward for screening. But of course, that's not enough. COSPEN is a small portion. We still need to do a lot to encourage others. Last but not least, I recommend the School of Medical Life Science at Sunway University and EP Plus Group to the commitment in raising awareness of colorectal cancer today. Let us take inspiration from this event to continue our collective efforts to enhance knowledge and shape the population perception on colorectal cancer screening and treatment, and ultimately improve colorectal health in Malaysia. Colorectal cancer is one of the cancer which can be prevented, detected early, and treated well if detected early. Together we can prevent colorectal cancer and defeat the disease in the country, and reduce the burden that we have in Malaysia. With lafaz Bismillahirrahmanirrahim, it's my pleasure to declare the opening of this colorectal cancer public forum titled Behind the Scene, Shedding Light on Colorectal Health. I wish all of you a fruitful discussion and they filled with valuable learnings of this event. Thank you.
With that, it will kickstart the session today. Thank you, Dr. Saleha, for the listening speech and for officiating this public forum. I would like now to invite the moderator today, Prof. Dr. Raja Effendi Raja Ali, Dean of School of Medical and Life Sciences, University, and the 6 panelists to be on the stage. Dr. Q Kwang Kiat, Head of Gastroenterology, Ministry of Health. Dr. Poh Kiat Siong, Consultant Colorectal and General Surgeon, Sunview Medical Center. Dr. Akilah Othman, Clinical Oncologist, Sunview Medical Center. Dr. Chua Tijo, Consultant Gastroenterologist, Sunway Medical Center. Prof. Abi, Cancer Biologist and Provost of Sunway University. Prof. Ili Renganadan, Professor of Public Health and Policy, Sunway University. Prof. Raja Effendi will begin the speech, his talk on the overview of colorectal cancer. So over to you, Prof. Raja Effendi.
Good afternoon, salam sejahtera. Thank you so much, all, and first and foremost, thank you, Mr. Pang and AP Plus for kindly sponsoring the event. Top management, Prof. Mer and Dr. Saleha from the Ministry of Health, and colleagues and friends. Ladies and gentlemen, it's a pleasure to be here. So the first 5 to 10 minutes or so, I'm going to go through the scenario of the colon cancer in Malaysia and also in the world. Now, can we get the slide? Right. So this is the trends of the death rates overall for the last many years, 1930 to 2010. If you focus on the colon cancer, the green for males and females, since 1930, many countries, except in Malaysia, the trend is getting downwards. So the screening has been proven to reduce the death from the colon cancer. If you look at the global age standardized rate for colon cancer, if you narrow down to Malaysia, the bluish color there is around 17 to 20 per 100,000 people in the country will get colon cancer at some stage. If you look at the standardized mortality, meaning that's how many people died of colon cancer, again, our region or focus to our country there,
is red, is quite substantial, given the increasing rate of the colon cancer happening in the country. Now, the three commonest cancer for Malaysian, ladies and gentlemen, today and the next couple of years might be changed. For men, the first one is colorectal cancer, believe it or not. Sometimes when we ask the public during the consultation, they may think that prostate cancer, liver cancer, but the data for the last couple of years or so, colon cancer, overtaking lung cancer for the last couple of years as the #1 cancer for Malaysian men. And for women, colon cancer is still #2 under breast cancer, but the incidence of the number of new cases and prevalence are increasing very steadily in our country. Now, these are quick facts of colon cancer in Malaysia. As mentioned by Mr. Pang early on, colon cancer is the second leading cause of cancer-related death in our country. And on average, about 1 in 33 have a risk, of course, depending on the risk factor that the patients have. Very important to say here that majority, 90% of the colon cancer arises from people who are 50 or above. It's very important to make a note also that the incidence of number of new cases for colon cancer in the young, in particular 40 to 50 or even less, is rising steadily, and the data is there. So something that we need to be aware of. Now, these are the slides telling us if there is no screening, what will be the impact of cases for colon cancer. You can see there of all the different colors, whether the green or the red or the blue signify the number of cases, the prevalence or different stages, they are more or less the same if there's no screening done. And telling you that colon cancer is a treatable, preventable, screenable, and beatable cancer, one of the most common cancer and cancer that we can screen to prevent the diseases. Now, if countries have the screening done, so you can see whatever that the number of cases will be rising, not surprisingly, because the impact or the public or the community attending for the colon cancer, but very importantly, whether the individual have the early stage or the late stage or overall, there is a significant reduction of the cases over the time. So as Dr. Nur Saleha mentioned, that this is very important because the number are rising steadily. It is estimated around in the country 3,000 plus or so new cases per year that we've seen from the whole country, either in public or private practice, something that we can save life quite easily by screening them all. So finally, colon cancer screening and save lives. So I think this is just to kickstart the forum that we have with our esteemed speaker here. They all look very less stressed or stressed here, look very stressed. Yes, so I'm going to there will be 2 rounds of questions, asking our panelists, and after that I will open to the public. You can ask whatever that you think appropriate for this cancer. So let us go to the first round of the questions that I prepare for them. I think this I would like to be from how the cancer is formed to how we treat the screening, or how we produce or start the screening process, like bench to the screening policies. You know, how we have the panelists from cancer biologists up to the policymaker, especially Prof. Elil involved in the health white paper. So question number 1 to Professor Abi first, for all of you. So what is cancer and how does cancer arise from the large intestinal rectum, please?
Testing. You can hear me?
Yes, yes.
Oh, great. Okay. For some reason, that means I must be stressed because I don't feel my voice is amplified. Anyway, welcome everyone to Sunway University. So before I actually talk about cancer, can I just give a bit of a explanation of how our cells work and actually how our bodies work from a cell perspective? So when we actually talk about our cells and how we are as a body, there's actually a process called the cell cycle. And that cell cycle is actually a sequence of events that allows our cells to divide and duplicate but also when the cell is old or the cell is damaged, the cell then gets destroyed and it gets replaced. And this cell cycle process is extremely important and integral in actually maintaining our anatomical structures, our physiological balance, and what we always talk about, the homeostatic balance. It's a constant state that we're in. And it's this cell cycle is also the way in which we are able to grow from that single cell we were at some point to the beautiful trillion cells that we are today. And as we were growing, the cell birth rate is higher than the cell death rate. And that's why we're able to grow. And as we achieve adulthood, that's when the cell birth rate and the cell death rate kind of equalizes and normalizes. And as we grow older, then you have the cell death rate then increasing and the cell birth rate then reduces. And that's why you think that your grandmother seems to be shrinking, right? Or their wounds are healing slower. And so it's really important to understand that when we talk about cancer as a disease, it starts off with this imbalance of the cell cycle. And in cancer cells, for some reason and reasons that we now know and continue to learn, is that the cell birth rate is higher than the cell death rate. That's why the cancer cell starts growing a lot faster. And they are able to do that because the cell cycle is dysregulated, it's disrupted, because the genes that control. And what is genes? Genes are essentially the recipes and instructions that are in our cells that actually tells your cells, this is what you need to make. And what's it making? It's making proteins that allows your cells to do the functions that it needs. But when the genes that control the cell cycle, the recipe now is destroyed, and that's where you have mutations. Now that protein that is produced is defective, it can't actually do what it's supposed to do, or it's gotten a new function and now it's doing something bad. It's this bad agent that is actually creating this damage. And so this is how cancer starts. It starts as a disease of the cell cycle, but just like a teenager that continues to make bad decisions after it's made one bad decision, that cancer cell now that has acquired this mutation starts acquiring other mutations. And that's how it transforms from a normal cell into a cancer cell. Now the cell is able to cheat and evade the immune system. The cell is able to make new blood vessels on its own to be able to feed itself. The cell also acquires itself to spread into other parts of the body. And that's what cancer is. So really, when you ask what is cancer, I'll say cancer are actually a group of diseases. We have to understand that because cancer is not a single disease with a single factor, it's hundreds and thousands of combination of mutations that occur in that cell that determines the behavior of that cancer, which is also why same patients with the same type of tumor of origin will have different responses to therapy. And that's because of the genetics of cancer. But equally important to understand that cancer is a genetic disease, but only 5% of colorectal cancer patients actually inherit the genetic that increases their risk of cancer from their parents. The majority of mutations that we actually occur that triggers this process of transformation, which normally takes about 15 to 40 years from you having the first genetic mutation to ultimately actually having enough mutations for you to have cancer, actually is acquired through the different lifestyle habits, which I'm sure the rest of the panel are today. And when you talk about colorectal cancer, why is it called that? It's because the cancer cell, that original normal cell that started acquiring the mutation, it arises from the epithelium that lines the colon, the large intestine, or the rectum. And that's why it's called colorectal.
Thank you so much. So we have a cancer form now in the large of intestine. The next question to Dr. Chua, the gastroenterologist from Sunway Medical Center. What are the usual symptoms or signs that the patient with colon cancer present to you, please?
Okay, thanks for asking this question. I get asked this question very, very often in my clinics when I'm running the clinics. And this is a question that worries me because the whole purpose of screening is to find a cancer before the patient's actually symptomatic. So once you have symptoms, the cancer might be in an advanced stage. So the problem with colorectal cancer is that the symptoms are very subtle, and the serious symptoms often mean that you have a pretty late disease, which is very worrying. So without much ado, I'll talk a little bit about the symptoms. I mean, a lot of the subtle symptoms are things like a loss of appetite, just a slight change of bowel habit. Sometimes you notice a mucus in your stools. Sometimes you might feel that you have some indigestion. And the problem is that these symptoms are extremely common. I mean, most of us have had a bout of indigestion in the past, and you think nothing about it. Whereas the more serious symptoms like rectal bleeding, when you have inability to pass motion for a few days, those are what we call the late symptoms, or where you have lost a lot of weight. So by then, when they come with these symptoms, it is often in the advanced stages of the disease. So I personally, if I'm asked this question, I would say that the symptoms and the signs are pretty unreliable, and you cannot completely depend on it to make an early diagnosis. So which leads to the topic of the talk today, which is shedding the scenes on colorectal health and screening. So I do need to emphasize that if you are screening, you are looking at an asymptomatic individual.
Thank you, Dr. Chua. I mean, Prof. Abi mentioned, for your information, majority of colon cancer, in fact, 95% are so-called sporadic cancer, meaning that happens from the polyps, very little actually from familial or have some genetic mutation. And of course, early on symptoms may be none or asymptomatic. It's not good enough when the patient has symptoms like bleeding from the blood passage or low blood count or lost weight by the time the disease is very advanced. Now, cancer is formed, symptoms and signs is there. So the next question for Dr. Q, the head of service for the gastroenterology for Ministry of Health. What are the risk factors for the development of cancer? And what are the options for the screening that we can offer for individuals coming for screening for colon cancer, please?
Good afternoon. When you talk about the risk factor, usually we want to divide it into whether this is modifiable or is a non-modifiable. So if you're talking about non-modified, you cannot say I want to be born in that family with the no risk of low risk of genetic that can is a risk for colorectal cancer. So non-modifiable risk factor like your gene, you cannot modify. Some of the cancer is arise from the genetic mutation that predispose the patient to the colorectal cancer. The other risk factor will be certain GI disease, just like an inflammatory bowel disease. This group of patients, they are at risk of colorectal cancer. That's why this group of patients will be put under surveillance colonoscopy. So now we talk about what can we modify? What can we modify? Like Dr. Sahali has said before, if you are obese, you put yourself at the risk of a colorectal cancer. If you are lazy, you don't want to do physical activity, you put yourself at risk. The other risk factor is like the food you eat. You take red meats, you take processed meats, that put yourself at risk of colorectal cancer. That's why we advise you to take more vegetable, more fruits that will reduce the risk of colorectal cancer. When we talk about the second part of the question, we talk about the screening. When you do screening, you have to divide your patient to different risk groups. There are average risk group, moderate risk, and a high risk group. The high risk group are the one that genetically prone for colorectal cancer. When we're talking about moderate risk group, those are the person that are born in the family that they are family members with colorectal cancer. If you have a first degree relative, 2 of them have colorectal cancer, you are moderate risk. You have 1 first degree relative plus more than 2 second degree relative, then you are at risk, you are moderate risk of colorectal cancer. For those patients, for those persons that are at moderate or high risk, we will do a colonoscopy for surveillance. Next, come to the average risk. Average risk is like those of us they have no family history of colorectal cancer, but the age more than 50, then this group of patients are labeled as average risk, and they should go for a stool test. What we do now is called an immunoassay fecal occult blood. That means the test to detect the blood that present in your stool that is not visible by physical eye. For those that are positive, then they should go for colonoscopy. For those that are negative, then we'll do it yearly.
Thank you, Dr. Q. So we have a scenario about cancer is formed, showing the symptoms, what are the risk factors they have, is diagnosed properly now. So the question to Dr. Poh, the colorectal surgeon here, usually the patients ask, how you describe the surgery for those who are diagnosed colon cancer? Can I have minimally invasive or open surgery, please?
Yeah, up to today, I think colorectal cancer is still a very much disease that with the mainstay of treatment by surgical resections. Is unlike some other cancer like probably like lung cancer or nasopharyngeal cancer, you can give chemotherapy or radiotherapy, but colorectal cancer you have to reset it. So the principle of surgery for colorectal cancer is you're not going to just take out the tumor and leaving behind the colon. You have to take the whole segment of the colon together with the tumor in between. And then there's a safe margin of by standards about 5 centimeters in front and behind. So a lot of time when patient newly diagnosed colorectal cancer come to our room, we'll share with you like our surgeons little brain will start thinking how to take the tumor out, you know. So by looking at the CT scan, that's number one, and also the endoscopy. So we are hoping that the tumor is located far away from the rectum, far away from the anus. Why? Because imagine if the tumor is located just next to the anal sphincter, the anal opening. So by the principle of dissection, then that means you have to remove everything, including the anal opening. So the patient, he or she will have to end up with a permanent stoma. So whereas if the tumor is located higher up, like far away from the anal opening, like for example, 10 centimeter or 8 centimeter away, then it's a very good chance that you can reset the part of the colon and then try to join back the two ends together. So what we call the anastomosis of the colon. So a lot of time the CT scan will also tell us whether the tumor has invaded to any part of the surrounding organ. So these are the things that need to be removed together during the surgery. So for example, like for female, if the tumor is invaded to the uterus, then it had to be taken out together, or ovary or small intestine. For male patient, usually the rectal tumor, the high risk is, I mean, those locally advanced one, you go to the prostate. So those are the things that we look at on the CT scan. And then the next thing to discuss during the consultation is, as a surgeon, we want to tell the patient whether yes or no, you can join back the two ends of the bowel, or if it's not possible, then do you need to have a stoma? So a stoma is something that a lot of patients, they are very concerned. It's something that the surgeon create a hole, put a hole, and then pull through the hole with the intestine. So all the poops will come out to the stoma and collect into the bag, rather than going to the anus and pass out like naturally. So I would say nowadays with the advancement of chemo, radiation, and the technique, surgical technique, I think majority of patients with colorectal cancer will not need to have a permanent stoma. Yeah. And most of the time, they only need a temporary stoma. Temporary stoma means they just carry the bag for probably like 3 months, 6 months, or 8 months until they are getting fitter, until they finish all the chemotherapy. Then they went to the second stage surgery to close back the stoma. So those are the things that technique, the principle of surgery. Of course, nowadays there are many ways of doing all these things. So in the past, I mean, probably like 30 years ago, there only one way. I mean, only traditional way, where the surgeon make a big cut at the tummy about 15 centimeter, 1.5, okay, and then do everything's resection, take out the tumor, and then close back. So the wound is larger. So probably in the past 20 years, I would say, the minimal invasive surgery has become very popular. So of course, probably you have heard before like keyhole surgery, where the surgeon will create several holes on the tummy, usually about 4 to 5 tiny holes, size about 5 mm to 1 centimeter. And then through that, they put in the camera, put in the surgical instrument to do whatever I mentioned just now, to resect the tumor and then, bring it out. And yeah, so that actually from the study, they say that the outcome, oncology outcome is similar to the big scar, but the patient satisfaction, recovery, and then the pain, the complication is lower for minimal invasive. And of course, there another new kid in the block called robotic assisted surgery. So robotic assisted surgery is getting more popular in the colorectal field nowadays. I think Sunway Medical Center has got a few, I think 2 robots. It's probably one of the earliest private center that adopt this technique. So the advantage of this robot is they also help to do the surgery in the minimal invasive way. But then it comes with the advantage of more precision, and yeah, it give the surgeon more authority to control every aspect of the surgery. So I think there are many advances nowadays. So these are a few of the options.
Thank you, Dr. Poh. So we have diagnosed the patients, having the surgery. The next question to Dr. Akila Osman, the clinical oncologist. So usually the patient will ask after the surgery, do I need chemotherapy? If I do, what would be the potential benefits and side effect? And is it going to improve the prognosis of my disease? Please, Dr. Akila.
Now, certainly after surgery, the first thing that we look at is actually the pathological specimen. So what exactly is in this pathological specimen that suggests whether the cancer is going to come back, the cancer is going to relapse or not? The first thing that we see, if the cancer is very early, then certainly the chances of cure with surgery alone is very high. So you don't need any other further management like chemotherapy. But certainly when you look at the surgical specimen and you see, there are many factors here that suggest chances are if I'm going to leave this alone after surgery, it's going to probably come back pretty soon. So some of these are maybe people, when you remove the lymph nodes around the area of the cancer and there's got a high burden of lymph nodes. So lots of lymph nodes are involved. So although you do a scan and you see, there's no signs of disease anywhere else, chances are this patient's going to have what we call micrometastatic disease. So it's basically disease that has potentially spread, or in other words, being carried in the bloodstream, but not being seen on the scans yet. Okay, so these patients harbor a very high risk of the cancer relapsing very soon after. So patients like this, nodes positive cancer or cancer that is actually very advanced in that it has burst through the lining of the bowels. In other words, it's burst perforated. So these cancers, again, very high risk of the cancer coming back. We would suggest having a course of chemotherapy to prevent the cancer from coming back. In very simplistic terms, to try and arrest whatever cells that is still floating about throughout the body and killing them off before they can lodge elsewhere to cause the cancer to come back. So there are certain features that tells us these things. First of all, the nodes being positive, the lymphovascular invasion being positive, that is the area around the lymph nodes, the cancer being very big, bursting through the lining of the bowel, being a T4 cancer, the cancer sometimes our colleagues are not able to take the cancer off completely with a safe surgical margin. So the margins are not clear, which again is not a very good sign. Or sometimes for whatever reason, the node sampling is not enough. So we would like, a minimum of 12 lymph nodes to be taken out. And for whatever reason, sometimes we are not managed to get that. So that in a way is actually a bad prognostic factor for the patient. So it just suggests that the risk of the cancer relapsing is very high. So in instances like this, we would suggest what we call an adjuvant chemotherapy to prevent the risk of the cancer coming back. So adjuvant basically means treatment that is done after operation. Okay, so this is what we do. And when you talk about risk factors, obviously we will look at the patient themselves. So sometimes you're going to weigh if the cancer is going to be coming back pretty soon after the surgery, but do this patient have other risk factors? In other words, they have other comorbidities, they have other health conditions that's probably going to predispose them to maybe a premature death caused by other things other than cancer. So maybe they've got, very bad heart disease, maybe they've got heart failure, maybe they're very elderly and they can't cope with chemotherapy. So then we weigh the balances, the risks and the benefits, okay? So in patients like that, chances of them benefiting from chemotherapy is going to be, yes, high, but not as high as maybe causing them harm. Okay, so the potential side effects of chemotherapy varies from person to person. And as the name suggests, it's potential. Not everybody's going to get that list, long list of potential side effects. But the main worry about chemotherapy is that when we give chemotherapy for colorectal cancers in the adjuvant setting, so in the setting where we want to prevent the risk of relapse, is basically we use a group of drugs called fluoropyrimidines, and they can cause coronary vasospasm, which can potentially lead to heart attacks if you've got an underlying ischemic heart disease. So again, we need to evaluate the patient properly to make sure that they do not have a history of cardiac history, or if they do, then obviously we need to take certain precautions with regards to that. Other, potential side effects like nausea, vomiting, feeling tired, and all of that. The drugs, the supportive medications that we have these days are very good. So I wouldn't be too worried with regards to that. The main potential side effects, as I said, in terms of immune suppression and, cardiac toxicity, those ones we need to consider very carefully, and we will take precautions if we expect the patient to have a very high risk with regards to that.
Okay, thank you, Dr. Akila. Clearly, we're going to prevent all this like a journey of a cancer patient from definition of cancer to the chemotherapy. No question to Prof. Ele, Professor of Public Health and Policy, determinants of health are plenty. So how do you suggest or recommend to do really a nationwide population-based screening rather than just opportunistic screening for the Malaysian, whatever risk we have for colon cancer? Prof. Ele, please.
Prof. Afendi, thank you very much. Maybe let me start by, you heard today that this is the most common cancer among males. You heard today that is the second most common cancer among females. You heard that about 60–70% of those people who are screened and are already at the later stages of disease. How many of you knew about this? So that's the first thing we need to do, which is to raise awareness, make sure that people understand this is going on. Another big challenge is at the moment, when you look at screening, the main screening tool is a fecal stool sample. And when you look at public health screening, getting a stool sample is probably the most difficult public health screening tool. People are willing to give you blood samples, people are willing to give you urine samples, but to give you a stool sample, it's not very easy. And when I look at the people around here, we all have flush toilets. We need to have innovation to get stool samples. So people then, really step back and say, no, I'm not going to, they avoid that. So I think as part of the broader discussion and conversation, we need to think about what else needs to be done. And as Dr. Nur Saliha said, at the moment it's opportunistic, and ideally we want to move to a position where you have population base, which is much more broader. You have a defined group of people you go to and get them screened, and then you're in a much better position to pick up those at a very early stage. And probably one of the things about saying that this is, coming back to what you said, Abi, is that it takes some time for this cancer to evolve. So you can pick some of the early stages very early on if you do the screening early on. A lot of discussions have taken place in the country about what do we do, in terms of broadening the screening. And Dr. Nur Saliha, when I was looking at the literature, I came across the 2020 paper that you and the current DG and others wrote about colon cancer screening, and the proposal as to how you triage and how you get something going for that, which makes a lot of sense. We need to increase and then move from being opportunistic and get more into a population based. But having said that, I want to raise one very important issue that keeps coming up when you do public health programs: the whole issue of demand and supply. When you create a demand, you need to have the possibility to provide the supply to deal with that. So we can go ahead and push for more screening, but unless we have the capacity to respond to that, the results coming from the screening, we are, people will go back, the marketing people will tell you that if you say you're going to have a new iPhone, and when people come to your shop, it's not there, you've lost them. So I think those are things that we don't think about, but in public health, you really need to think of those things. And the other important thing that I think, Dr. Salia, there is a national cancer control strategy. The new health white paper is going to move away from sick care to health. Two of the pillars are very relevant here. The first pillar is about improved and better healthcare delivery. And the second pillar is about promotion and prevention. So those are two big things that we need to keep in mind as we take this forward. It is very important that we are getting awareness on this, but then, let's work on this. And I'm very happy that we have private sector, academic, public sector here, because we need to have the plan, and all of us need to work together on that. Yeah, thanks.
Thank you, Prof. Elil. So I'm going to go straight to the second round, back to our cancer biologists. All these questions actually asked by the public. So, they were asked, they heard about what is polyp, is there any blood test that we can do to screen patient who get suspected colon cancer? Please.
All right. Okay, so I want to go back again. I like the way Dr. Q introduced risks, the unmodified risks. And one unmodified risk that perhaps was not mentioned is aging. And that's something, again, they're going to age. And I think a lot of us have to understand that cancer is also, a disease, that aging is a factor. Because as we talked about how that cell, the normal cell transforms, into a cancer cell, it takes time. And that time can vary depending on the type of mutations it occurs. And this is between, say, 15 to 40 years. And I like to use the analogy. It's like driving too. The longer that you're on the road, the higher the likelihood of you getting into an accident. So the longer you live, there's a higher risk of you getting cancer. And things like slippery roads and potholes are your unmodifiable or modifiable risks that increases that risk of you getting cancer or accident if you're actually on the road. And so when we talk about screening, when we talk about it's about you deciding, am I fit enough to drive, right? And actually knowing where you can actually modify and understand. So I think today you already heard about the fecal occult blood testing. And that test has, continuously been improving. And now you have immunofluorescence and various different techniques. And that test alone has been shown to be able to save, 10% to 30% of lives, right, from actually dying from colorectal cancer. And maybe some will argue about its specificity or sensitivity may be low, but that same problem is also a good one because it is able to also identify potential other complications, including inflammatory diseases and various other things. And so, although there are, certain limitations with the test, it is the best test available now to reduce your risk. And talking about risk, it's also recognizing, and understanding, where or what your risks are. And especially in the context of families, right? I mean, a lot of times, when I go to funerals, sometimes we ask, how did he pass away? I don't know, but I'm paying my last respects. And I think it's really important, as a culture to actually truly understand, how your relatives actually passed away, or how your grandparents passed away, or how your uncles passed away. Because as Dr. Q mentioned, having direct relatives that have actually passed away from colorectal cancer will actually change your risk. And that perhaps will actually change the way you decide, whether you should get your screening or not. A second thing that I didn't mention, but I alluded to the fact earlier about the fact that 5% of individuals actually have, an inherited form of cancer. And that's because of the genetic predisposition that they inherit, not that the cancer was transferred to them. For that particular groups of individuals, you can actually get a test. You can do a genetic test and actually identify, whether you actually have that particular mutation, whether it's familial adenomatous polyposis, FAP, or the hereditary non-polyposis or colorectal cancer, HNPCC or Lynch syndrome. And I think your clinicians here will be able to advise, on basically what genetic test. And if you have that genetic test, then certainly what your risks is, and your risk is increased a lot more. And this goes to then the polyps. So polyps are essentially benign projections, out of your mucosal lining of your colon. But they are benign. They shouldn't cause much complications unless you actually have FAP or even HNPCC, but mostly FAP, where you can have hundreds and thousands of these polyps. I read it, they probably see it in person, all right? And it's important to understand that basically why this is the case. Remember, I talked about how it takes 15 to 40 years. But if you don't have that inherited predisposition, your time starts when that first mutation occurs in your cell. But for individuals that inherit that particular mutation, basically from day one of your conception, the time has already set. Every time your cell divides, is it going to acquire more mutations? So you'll find that individuals that have, say, a mutation in the APC gene in FAP, by the time they reach 21, 7% of them already have polyps. So therefore, their colon cells are already undergoing changes. And that polyp can stay on as a polyp forever, or it actually can become a tumor and a cancer. And that can metastasize later on. And in individuals with inherited risk, by the time they reach 40, the chances of getting cancer is almost 100%, if not 90%. And so for this individual, that genetic test, that simple blood test, is extremely important. But to 90% of individuals who will get cancer through that sporadic cancer, your best bet is actually through the fecal blood occult screening, coming and volunteering, doing it rather than being forced to do it, and actually recognizing that it's not about the therapies, but the earlier you actually catch your cancer, that is your single best predictor of your outcome. And that actually belongs to you, and it's your decision when you actually go and see the doctor.
Thank you, Prof. Abi. The next questions, Dr. Chua, usually public will ask what will be the appropriate age for Malaysian to be screened, given, let's say, in 2030 or so, to add on 15% of Malaysian will be 60 years of above. So can you share your experience with us, the appropriate age of screening for colon cancer?
Yes, this question has actually been alluded to by Dr. Q. He mentioned that the appropriate age for screening in Malaysia is between the ages of 50 to 75. Now, these are based on the guidelines which were issued by the Ministry of Health, and that was published in 2017. Now, just to take a step back, you have to understand a little bit about these guidelines. These guidelines are formulated based on the local circumstances. What are the resources available to us, what we can do to screen, and what we can do to investigate further once a positive screening comes back. So these guidelines, actually, if you look through all the guidelines, they vary from country to country because of all these factors. So the latest guidelines from 2017 state that you should be screened between the ages of 50 to 75, depending on your risk stratification. Now, I do need to stress that if you are symptomatic, it is not screening. You are actually investigating if you have a cancer or not. And that automatically puts you into the high-risk group. There are newer methods of screening in the market, like fecal M2PK, but it's not widely available at the moment because of the cost. And when you look at screening between the ages of 50 to 75, you have to look at accessibility and cost as well. Fecal screening is not exactly the most comfortable thing to do, but it's not as difficult as well. I do have patients who come in and say that oh, I don't mind doing a stool test, but I'm afraid of needles. I don't want a blood test. So we can do that as well. Also, as Dr. Q alluded to regarding colonoscopy for the high risk and average risk patients, sorry, moderate risk patients, there are patients who are very anxious, who are very worried, and they may fall into the low risk category. So my stand is that if they want a colonoscopy, I won't deny them the colonoscopy. I would still screen with a colonoscopy, even though they are low risk. But by and right, the guidelines here state that the screening is between 50 to 75. And the reason why it stops at 75 is because they feel that there is no additional survival benefit if you screen up to 75. That is why there was the age cutoff. But if you look at certain other countries like Australia, they start their screening at 45. Also, as alluded correctly, if you have risk factors or particularly genetic risk factors, you would want to start screening a lot earlier. And I'm often asked how early is early. So generally, I would advise if you have a family history to start 10 years before the first case was diagnosed in the family. So assuming that you have a relative at the age of 35 who's had a colorectal cancer, you better start screening at 25. So that answer varies depending on the risk factors.
Thank you, Dr. Chua. Straight to Dr. Q, the role of family medicine specialists and general practitioner, they are the ones who actually the feeder to the hospital-based doctors for screening colonoscopy. So what would be their roles, you think, to be active, proactively participate in the screening of colon cancer?
For the family medicine specialist, as well as the medical officer in the in our health clinic, and for those general practitioner, the role is of course we want them to advise the asymptomatic patient to come forward to do the stool or cord blood. Okay, that is the best if the patient fulfill the criteria more than 50 to 70. Sometimes we do screen after 75 if they are fit. So and then that's it. That's the best group of patient that we want. But some patient will present late. So for those patients that present late, they should be able to pick up the what you call alarm signs that the patient might have colorectal cancer and send to us earlier. And we do not advise them to do the fecal or cord blood for those group of patients because it's positive or negative, you are going to send to us for colonoscopy. There's no use to have a step that some of them do a test before they send to us. But I think the appropriate way is all the symptomatic patients should be referred directly to the facility that have the capacity to do the colonoscopy.
Thank you. Dr. Po, sometimes the patient or, self-diagnosed with the hemorrhoids because of bleeding from the bad passage. Common things happen commonly, and then we got them late. Any condition that can mimic the colon cancer in your practice, please?
Yeah. So hemorrhoid is a very, very common condition. I think all over the world, especially in developed countries. So they are saying that out of 10 person, probably 8 or 9 will have hemorrhoid. Whether depend on the symptom is severe or not. So if you have notice that, like, let's say this is such a common condition. So obviously, a lot of patients who have rectal cancer, colon cancer also have that before. And then the symptoms of the hemorrhoid is quite similar. So what is symptoms of the hemorrhoid is usually 3 things. Number 1, per rectal bleeding. Yeah. Number 2, they can feel that there's a swelling that prolapse out if the hemorrhoid getting bigger. And number 3 is maybe pain. But most of the patients who have hemorrhoid doesn't have pain at all. So the commonest one is still bleeding. Yeah. And what are the symptoms of rectal cancer is also quite commonly they have bleeding as well. But you compare the both hemorrhoid and rectal bleeding, the rectal cancer, there are some subtle differences. In terms of the blood, hemorrhoid bleeding tends to be bright red and very, very fresh because the hemorrhoid located just next to your anal opening. So when the stool squeeze through, then the blood obviously will be just fresh. Compared to, let's say, the tumor caused the bleeding, then it depends on whether location of the tumor, whether it's high up Sometimes the colon tumor is the one that bleed, let's say from the right hand side of the colon. By the time it travel all the way down to the anus, it has turned into a maroon color or even dark black color. So, but then if the tumor is very near to the anal opening, like a low rectal cancer, then the color of the bleeding could be very similar. Because I have patients who have come to me 51 years old with a hemorrhoid. And then in the clinic, I put in the protoscope. Protoscope is a small scope, 4 or 5 cm, that you can visualize the hemorrhoid. And that patient had hemorrhoid. But when you do the colonoscopy, then he had a tumor just sitting 7 cm above the anal wall. So it just missed by your finger. So it can coexist. That's why a lot of patients who come, when you ask them, oh, how do you diagnose the rectal cancer or colon cancer? They will tell you, oh, it started like 2-3 months ago, and they thought it's a hemorrhoid. That's why they didn't come immediately. So I think most of the time, I think the important thing is you had to be careful. You're not sure how to differentiate, then better get to see a general practitioner or gastro. Then on the high risk group, then it's better to have a scope done. Yeah.
Thank you, Dr. Po. Dr. Akila, we are living in the precision medicine era. Can you share with us a little bit about targeted or immunotherapy that possibly can be given to patients with colon cancer, please?
So targeted therapies and immunotherapies, the current hype now, so it's relatively new. Not that new, but relatively new. Certainly with colorectal cancers, in the past, obviously, we only use chemotherapy, etc. But as we test further and further into the biology of the cancer itself, we know that everybody's different. So if we don't test, we would not know whether there are any specific mutations in the actual individual's pathology sample that suggests that this patient is going to be beneficial in terms of using these agents, these drugs. So what targeted treatment does, it basically targets, as the name suggests, targets specific receptors in the body, which in very crude terms is going to starve the cancer or prevent the cancer cells from growing further if we actually block these certain receptors. And again, in very simple terms, immunotherapy basically uses the body's immune system response to actually target the cancer cells and fight off these cancer cells. But not everybody is going to be suitable for these treatments. In this current era, in this data, what we generally have at the moment is this is being used in advanced cases of cancer. In other words, stage 4 cancers, cancers that spread to other parts of the body, or cancers that cannot be operated on. So basically advanced cancers. And it also is used in people whose molecular biology, basically certain targetable treatment options. So we can't give it to everybody simply because you can give it to somebody and it's actually not going to be beneficial. In fact, it can be detrimental. So certainly, when somebody comes in with colorectal cancer, if they're thinking or down the line of targeted treatment or immunotherapy, we need to test further in terms of the specimens.
Okay, thank you. And the last question for this round is Prof. Elil. How can the public health specialists intervene to be on board for the prevention of colon cancer in Malaysia, and how the public and private partnership actually can improve or can do something to run the show of colon cancer screening? And a special question to you as well: how can I add on question? How come the health white paper affect the colon cancer screening for the next 5, 10, 15 years, please?
Thanks, Prof. Effendi. A pitch for public health. So a public health physician, a public health specialist, you have to think in terms of evidence to policy to practice. That's a very simplified form. So when you think about a public health physician or public health specialist, contributing to colorectal cancer control. So if you look at evidence to make sure that epidemiological evidence, treatment evidence studies, studies from behavioral studies are all taken into consideration. From the policy dimension, you want to make sure that the national policy is taken into consideration, global policies that the World Health Organization sets, best practices that are available over time, that those things get taken on board. And then you come to implementation, the practice. The practice is about implementation of a program, about monitoring and evaluation of a program, but also about how do you find the right partnerships. Yeah? So implementation would mean, let's say, making sure you have a right campaign, awareness campaign. You need to make sure that you have the supply chain there in terms of, okay, having, like I said, the response, being able to deal with people who have been screened positively, etc. And the partnerships dimension is to make sure that all the players who can contribute to this broader control program are contributing to it. Your second question is about how does private and public sector work together? It's always a very challenging one, Prof. Effendi. And I think the ideal case scenario, if I were to create a world, in that world, we would have a common plan. And within the common plan, we would have primary care providers, which would then be, colleagues have mentioned about the medical officer, the health worker, community health worker, the GP, private practitioners on one side, looking at it at the primary care level. And at the tertiary care level, then you have the specialists who have their own practice. You have the hospitals, the private hospitals, the government hospitals working together and saying, okay, we have to treat 100 people. How are we going to divide among ourselves? Who has got the capacity to do that? So that's would be my ideal case scenario. And coming back to the ideal case scenario, the health white paper is trying to get us to there, yeah? That there's more collaboration between the private and public sector. There's more recognition of where the resources are, more recognition of what capacity is needed, at what point, and how does the totality of the healthcare system come together. So I think that would be a very simplified way of responding to your question. Thanks.
Thank you. I have many questions coming to me now, but I'm open to the physical attendance here for to ask our extremely busy panelists spend time with us on Saturday afternoon. Please raise your hand and ask questions. If not, I will keep asking them. Anyone? Please, sir. Can we give mic?
It's okay, a bit husky. Hope you don't mind. Well, from the eminent experts, thank you for all the info. It is very, very informative, very insightful, and very in-depth info that I'm hearing from all the experts in Malaysia. Someone mentioned about immunotherapy. Of course, conventionally, we know about radiotherapy, chemotherapy, surgery, and now comes immunotherapy. In particular, I suppose I'm not a clinician, stem cell therapy will come under immunotherapy, am I right? Or is it a separate stream? Correct me if I'm wrong. In this stem cell therapy, from what I have come across, quite a lot of stride has been made, progress, in the various ailments. To put it simply, even in the case of simple asthma, they have done it, I think, back in Singapore some time back. And it's under NUS. And they have made some remarkable progress. And even cure, which is unheard of in asthmatics. So in the field of colorectal health, has anything been done in the Malaysian health profession across the board? I don't know whether private or public, since all the experts are here. And I find it quite interesting because personally, I feel if it can be taken in full stride by the experts or by the interested parties, I think it will make a great stride towards health being of the patients in the future or in the very near future. Please, thank you.
Right. We certainly welcome many new advancing treatment options, and options are definitely better than none. All right. Stem cell therapies, as you say, has made a lot of advances recently. And so far, the data we have at the moment is actually on hematological malignancies, so lymphomas, leukemias, but we do not have any strong evidence yet for solid-based cancers. And solid cancers like colorectal cancers, there's no data yet on stem cells. So that's why we're not doing it at the moment. And with this kind of medications or treatment advances, I would say, they go through very stringent processes of trials or regulations to see that it's actually beneficial to patients. So at the moment, we still have other options that are available. So stem cell therapy is there. It's still in work in progress, I would say. So we will definitely, await, the future advances. If it works, then it's great. But as I said, at the moment, we're not there yet for solid cancers.
Any other questions, please? Yes.
Good afternoon to all here. I'm from the nursing faculty from SMLS. Okay. I just want to ask, in pertaining to the stem cell, of course, we have here the leukemia patient getting bone marrow therapies and stem cell transfer and all that. But I've heard and I've come across, and even I also consume, there is algae that related to enhance our stem cell production from our bone marrow. So we already have existing stem cell, maybe when we are ill or to get us better or get more new cells, as Prof. Abi said, the dying one is more as we aging and the new cells are less. So maybe we have to stimulate somewhere. So they have taken algae, the blue-green algae studies have shown in the US. So I don't know how far there's a research done in the medical health. And of course, the products from the companies that they are doing, they've done the scientific research. And my second question is that the only way of screening for this colorectal? Is it only way is by stool and colonoscopy? Is there any blood that we can sort of like we check for tumor markers also? Thank you.
Thank you. I think we have to go back to Akila for the first question, please. And a bit comment from the Prof. Abi. Please, Akila can start first.
Right. So to be honest, when somebody's got a diagnosis of cancer, right, people go online. People go on internet, they speak to people. There's lots and lots of anecdotal stories everywhere, left, right, and center to say, if you take this, it's gonna be, better for your immune system. It's gonna do this, your cancer is gonna disappear. It's gonna prevent the cancer from coming back. If our body is actually that simple, then it would be great. And then actually it would be great for all of us, because then we don't have diseases and we can actually cure diseases, and it makes things a lot better. Okay. Unfortunately, our body is a lot more complex than that. It's not a matter of taking one certain type of food and it's going to boost, everything in your body, and it's going to make things disappear. It's going to make things, absolutely curable. Yes, all of us need to go on a healthy diet, healthy lifestyle, etc. But all our, nutrients, etc., comes from a variety of sources, not just one, and especially not one that is being marketed or produced in, for the mass consumption in terms of profit or something along those lines. So to be honest, with these things, as I said, if you just, put a search online, there's 1,000,001 things out there to say and claims that it can do this, it can do that. We are not there yet. We're simply not there yet. And I think, if you think logically, if only it was that simple.
Prof. Abi, want to add, please?
Yeah. No, so this is a very tricky question. And I think every time when people know that I work in cancer biology, they always tell me, but you know what? The solution is just turmeric. Just eat turmeric and then you'll not get cancer. And I say, but look at the number of Indian patients who eat curry every single day, and yet they still develop cancer. So obviously it's not the solution. But I think what you bring up is the understanding that in today's world that everybody's evidence, for a doctor, it might be called anecdotal evidence, but for that individual, they truly believe that it actually is improving their health. And, to the gentleman that asked that question and to you, we agree. I think that the thing is that there's still a lot of unknowns. We're starting to understand that the influence, we didn't talk about the microbiome, but the microorganisms that are in us. And that's why Professor Sibrandis is a big champion of this. And it's not even the microbes, but it's actually the metabolites of these microbes that can influence our health. So all of these, are things that are actually moving along. But from a public health standpoint, and I think as medical professions, and that's why the answer by Dr. Akila was, it's the non-maleficence comes before beneficence, which is that, if you're going to do an intervention, if you're going to recommend something, you must make sure that it's not causing harm, right? And then the second is benefit. But having said that, I think I'm also hoping that with the new white paper, Malaysia has been very slow relatively to some other countries in its adoption of maybe new novel ways to do and construct clinical trials and investigation of potential new forms of therapy, including stem cells, for example, not for cancer, but even stem cells in general. And I'm sure you can respond to this. But to the question, stem cells, there are two parts to this. The reason why leukemias and blood cancers is because that stem cell is actually now going to be used to regenerate the cells that are depleted from the therapies that has caused. But in the case of colon cancer, the stem cells that they allude to, it's actually, for example, mesenchymal stem cells. They are not meant to reconstruct the colon, but actually some of the papers have shown the immunosuppressive abilities to maybe help certain areas that for example, the body is now not immunosuppressive, immunopromoting. So basically in the case of cancer, so if you're immunosuppressive, the stem cells might be able to modulate your immune system. But all of these are very small trials and actually haven't been done in the large scale. So I totally agree. We can't endorse any of them, but certainly that's growing. And that also is to the question of non-invasive tests. The reason why occult blood test is still being used is that because there's evidence and we know that it saves lives. So instead of going and finding some potential tests, this is something that we should be able to use and recommend. But a lot of research is being done at the moment. So liquid biopsies, circulating microRNAs, various different other tests that are actually evolving. And I imagine over the next couple of years, you're going to see more and more tests. But the first question that he asked is, how can we make sure that these tests are not just, opportunistic tests, but actually people are coming forward and making sure that they make the right decisions to get the test that they need based on their risk. And then, of course, do the therapies that actually this test ultimately recommends. But I know that probably someone here can actually answer regarding blood markers, not used as a diagnostic or a screening test, but perhaps as a post-therapy monitoring.
Maybe Dr. Chua want to comment a bit the utility of tumor markers, CEA, for example, in the screening, or is it just waste of time?
Well, the problem with the tumor markers and screening is that not all cancers display the tumor markers. That is the problem. So I can allude to all of us in clinical practice. We have seen stage 4 cancers where the tumor marker remains absolutely normal. So if you're going to rely on just a tumor marker to diagnose the cancer, you might actually be missing the forest right in front of you. I do believe there is a lot of commercially driven intent in these tumor markers, because if you go to a lab and you do a blood test, they do a battery of tumor markers. And that is a constant bugbear for us clinicians, because they do things like CA199, they do things like CEA, and they are barely elevated. And you don't know how to make sense of it sometimes. But the problem is once they come to you with a tumor marker, you end up with a lot of unnecessary investigations, and ultimately nothing comes out of it. So to just give you a little bit more data, I mean, in stage 4 colorectal cancer, as Akila can tell you, about 25 to 30% of patients do not have a positive CEA. So you're missing as much as 1/3 of cases. And again, the whole talk is about preventing the cancer early and detecting it early. The tumor marker is just not good enough to pick up an early cancer. It might be okay for a late stage cancer, I mean, I might get a tumor marker which picks up 100% of stage 4 cancers, but that's going to be pretty useless.
Thank
Hope
you.
that answers your question.
Thank you. Prof. Elil, you want to add, please?
No, I just wanted to add to what Prof. Abi was asking. Does the white paper take into consideration the need for research? Yes, it does. There is one of the strategies is about strengthening research and looking at a national research strategy that is broadly identifying what are things that need to be done and trying to be forward-looking. Yeah, I think it's the whole idea is future-proofing. So, looking forward. Thanks.
Any other questions here? Yes, please. Give mic.
Hi, I'm Jane. I'm a staff in the School of Medical and Life Sciences under Prof. Afendi. Okay, Prof. Elil mentions that the cooperations between government, university, and also community community is very important. So I think the number one questions for the community is the cost. Okay, so this one. So I think the cost is not communicated until now, this hour. And then the second question is, I think you see a lot of bantuan for the B40 is always money. Why not? I have these suggestions. Why not it become a health screening kind of things, bantuan to the B40? That's number one. And another suggestions is personal tax refund, tax relief. Because in the tax refunds, it's always how much to upskill yourself, taking care of your parents. A lot of this kind of in the tax refund educations. But however, the health screening, I guess the next budget, the Ministry of Health could be a part of it for our tax refund, so they can promote the community to really can go for a health screening and do this kind of screen scanning, have a better health, rather than just upskilling, educations. All these things are very important, well taken care of, I guess. Thank you.
Comment, Prof. Elil.
No, thank you very much, Jane. Jane, I think we tend to forget that Malaysia has probably one of the best healthcare systems, affordable systems in the world. So anybody can actually walk into a public clinic and they will get the treatment, the diagnosis that they need. The question is a question of time. Yeah. So depending on availability of capacity, etc. So that's the issue. And I think we sometimes don't give that credibility or that recognition to the Malaysian system. We have a universal health coverage, generally, and I think we need to think about it. I agree with you. Things could be better. And I think making people understand that, okay, it is available there. Yeah. And on the other side, also reducing the burden of health for the healthcare workers, because one of the challenges we have is overworking and people, when they come there, when patients come, staff are really overburdened. They're not able to, manage all these things. So I would think that the conversations that are taking place, I mean, all of us, I think we should be very happy that we are in a very, very interesting time, because a lot of conversations are taking place. People are talking about overworked doctors. People are talking about lack of capacity. People are talking about making sure nurses have better deals. So I think, let's be constructive, very helpful comments, and I think we can try but at the moment, I think the thinking among the Ministry of Health is to make sure that we get the GDP to 5% for health. That's what the health white paper is trying to push. So because if we get it to that level, then a lot of the things that we are talking about here is already being dealt with, rather than going piecemeal for saying, okay, let's try and get this sorted out, let's try and get that sorted out, and so on. And I think the biggest challenge for us in terms of bringing that up to the 5% is going to be our tax people, our finance people. Yeah. Thanks a lot.
Thank you. We have 5 more minutes. There's a question here, maybe Dr. Q or Dr. Po, Dr. Chua. Is colonoscopy very painful procedure? Number 1, not yet. Number 2, is this 100% effective to screen for colon cancer? Dr. Q.
It's very difficult to answer that question.
Make it easy now.
Okay, make it easy. I do not think colonoscopy is painful because you will be put under sedation during the procedure. I think the main feedback I get from my patient is the preparation before the colonoscopy that is suffering because you have to,
Agree, the audience? Agree, okay.
because you have to first you have to change your diet. Second, you have to take plenty of water. We are talking now about 3 to 4 liters within that period of time to wash out the feces. Because there's no point for me to put the colonoscope inside and look at your feces.
Okay.
I'm going to miss all the tumors.
You're
all
going
the
to be a
polyps.
plumber. You're going to be a plumber, is it? Yeah.
And then you can't wash out the feces actually. It's very sticky. So that is a problem for us because if you are going for colonoscopy, I advise you to follow the instruction as it is. The problem is in the government hospital, you pay 23 ringgit for a colonoscopy. That is a problem because they think that these are so cheap. They don't think that you need to follow us because they will say that if I cannot prep this time, I will do it another times. That will cause a burden for the public hospital. That is a problem. So for us to improve for that, I think the public knowledge about what's the constraint in the public hospital need to be there. I think the public health side can improve on that.
We blame Prof. Elliot not do
Yes.
good enough at the moment. That's your duty now for the next couple of months. Dr. Chua, you want to comment? Can we prevent 100% cancer from colonoscopy examination?
Well, no. The simple answer to that is no, because when you put in a colonoscopy or colonoscope, you might already have a cancer. So how do you prevent that? Okay, but aside from that, I mean, there are blind spots in the colon when you're doing the colonoscopy. So if you have small, tiny little cancers which are forming, there is still a chance that you can miss the cancer. That's one. Number two, if the preparation is inadequate, and sometimes, this happens in the public sector, you put in and it's not adequately prepared, you might have some feces overlying the tumor and you might miss that. And there are also blind spots which are missed if the colonoscopy is rushed through. But by and large, it is still the best method for detecting cancer. I would say that your sensitivity or your pickup rate you're looking at about 98 to 99%.
Dr. Po, you want to comment? Colonoscopy.
Yeah, I fully agree with the experience of colonoscopy. I haven't done mine yet. But most of the feedback from patients when they wake up from the sleep, the colonoscopy is they will probably ask you, when are we going to start the colonoscopy? I say, done already. So that is the short. I mean, they probably don't even realize. So I agree that during the procedure, usually not painful, but the preparation is. And yeah, but among all the screening tools that we have, I think colonoscopy is still the gold standard, despite the high cost and also I mean, it's tedious to do the bowel preparation or what. Many years ago, there's a study, I think US Polit study that showed that it had actually the only screening test that reduced colorectal cancer incident. So, but of course, we had to have multi-layer, different type of the screening, not only colonoscopy. So for those people who doesn't have the access to colonoscopy, then what they do? I mean, if they go to the government hospital, probably the waiting list is long or some whatever reason. So they can choose to do some other thing, like fecal occult blood. Now we had the N2PK test. So there are many different types. So cater to every different needs of the patients.
Thank you. Any last question here in the hall? Yes, please. You would like to make appointment for colonoscopy or what?
No problem.
Please.
Yeah, hello, I'm Juan. It's just a simple question from me because the panel mentioned about the cause of cancer just now. Is either genetic or from the lifestyle. We should eat more veggie, fruits, and less meat. But as a commoner, I heard a statement about cancer love sugars and craving for sugars. Can a panel comment on this statement?
The panel is go to Pro RB
Okay.
because he likes sugary drinks.
Yeah. 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 So that particular piece of work came from, again, experiments that were done. And of course, like I said, the cancer cell is dividing a lot faster than a normal cell. So it will uptake more protein, amino acids, sugar, and what have you. But I think, but I maybe, you can answer this question as well. But I think, if you're talking about, will the sugar drive the cancer incidence? Number one, sugar is not carcinogenic. Your glucose molecules don't go into the cancer cell and cause the mutations. And so if you're talking about it driving the process of cancer, the answer is no, right? And for a cancer patient, at that particular standpoint, you probably need to have sufficient nutrients and sufficient sugar in your body to withstand and withhold all of that. So you need to be well nutritioned. So I've heard a lot of people depriving themselves, of sugar because they think that's the way to starve it and it's going to die. No, we talked about how cancer cells can even make their own blood vessels. Actually, that's probably one of the ways, Dr. Akila also treats them by blocking the ability to make those blood vessels. But so, by depriving yourself of sugar, that's not the way to stop cancer. But this would be a different answer if you're talking about diabetes control. Yeah.
Thank you. Dr. Akila, you want to add?
So I think it's not that cancer cells love sugar. All cells love sugar, right? Your whole body basically depends on sugar to thrive, to function normally. All right. It's just that cancer cells, as Prof. Abi said, they grow faster. So when you feed somebody who's got cancer, the ones that's needing more energy levels, more energy, so they use up more sugar. In other words, they go and run and take whatever sugar that's going to come in. It's your cancer cells because they grow faster. So same like your brain. So if you don't you don't have cancer in your body, then you've got these fast-acting cells like your brain, other things. They're going to take up the sugar because that's your basic energy source. One thing I'm going to point out is even if you starve yourself, or rather you deprive yourself, I would say, of sugar, whatever you're taking, protein, other forms, they will be converted to glucose. So because that's what your body, that's the basic thing that your body requires to function. All right. Added sugar is not good for all of us. All right. Added sugar is basically, say you're having a glass of drink or food or whatever, and you purposely add, heaps of sugar into it just to have that sweet taste. That's not good because indirectly it leads to obesity, or other diabetes and other diseases. And that in itself can have a risk to cancer. In other words, you can have, the risk of cancer is higher, especially certain cancers like breast cancer, endometrial cancer. If you've got, obesity, then the risk is higher. Ovarian cancers, things like that. So certainly all of us, we need to be healthy. So it's not just sugar, as simple as that. We're talking about added sugar. There's lots of natural sugars that's present, i.e., in fruits, in vegetables, in things like rice, which is starch and is going to be converted to sugar. So that is okay. So we need to be sensible about these things. All right. Added sugar. So things like lots of cakes, lots of sugary drinks, all of us, that's bad for all of us, not just, anybody who's got cancer. So we need to be, a bit sensible about these things, making, correct decisions and, thinking further and how logical this thing is. All right.
Prof. Ali, please add how many teaspoons of brown or white sugar we have to take every day now.
I just want to tell one, you and I have got a genetic problem. We like sugar. And people may not accept that, but it is genetically in us. Yeah. So we have to accept that. Yeah. No, but I just. Yeah.
So I think with that, any questions from the audience? If no, let us give a big hand to all the expert panelists here for today. And thank you so much for being here on the Saturday afternoon, physically and virtually. And pass back to Chairperson, Mr. Zaim. Thank you.
Thank you very much, Prof. Effendi and the panelists. It was a very informative and insightful session. You may return to your original seat. Now we have come to the end of the session. We are delighted to announce that EP Plus Group is presenting a research grant to Sunway University. Their support is directed to raising awareness about colorectal cancer, which lies at the heart of their philanthropic endeavor. I would like to invite both Prof. Brandes and also Mr. Pang Siming to the stage. Prof. Sibran will accept the symbolic grant from Mr. Pang Siming. Thank you very much, Mr. Pang and Prof. Sibran. Now, I would like to have Prof. Raja Effendi to join us on the stage to present the token of appreciation to our esteemed guest of honors. So I would like to invite Dr. Nur Saliha binti Ibrahim Tamin. And also Prof. Brandes, the president of Sunway University. Announce. Now I would like to invite the panelists to receive the token of appreciation from Prof. Raja Effendi. So we acknowledge the appreciate their valuable contribution, ensuring their expertise and insight during this event. So Dr. Q Kwang Hian. Dr. Poh Kiat Siong. Dr. Nur Akilah Othman. Datuk Dr. Chua Tijo. Prof. Abi. And last but not least, our Prof. Ilir Linganadan. Okay. It's not the last actually, it's another one. Next, can we have Mr. Pang Siming to join us on the stage to present a token of appreciation to Prof. Raja Effendi, our esteemed moderator, for his instrumental role in uniting us today in the battle against colorectal cancer. His effort in raising awareness and bringing colorectal cancer to the front of public attention are greatly appreciated. Mr. Pang and Prof. Effendi, please remain on the stage. We are going to take a group photo. So I would like to invite all the panelists and also the guests of honor to the stage to take a group photo. So who will give the instruction? Thank you very much, everyone. With that, we have come to the end of the event. There are light refreshments served for everyone outside of the auditorium. Thank you very much for everyone for attending, and we wish you a pleasant evening.